When a clinician presses down on the skin to place an arterial or central line, they operate in spaces where margins are measured in millimeters. A slight deviation off target can puncture the wrong vessel, leading to severe bleeding, tissue damage, or the delivery of critical treatments into the wrong part of the circulatory system. To navigate these spaces safely, you need a precise anatomical blueprint. We will map exactly how to locate these vessels before you ever begin a procedure. Knowing exactly where to look beneath the surface before the needle ever touches the skin is how clinicians guarantee patient safety and procedural success. This split-screen diagram lays out the core difference between these two lines. On the left, arterial lines, or A lines, are used for continuous blood pressure monitoring and drawing arterial blood gases. On the right, central venous lines, or CV lines, provide central access for administering drugs and fluids. You must never cross these purposes. Administering standard IV fluids or routine medications into an arterial line can cause catastrophic tissue damage and ischemia. To ensure you target the correct vessel every time, clinicians use a universal three-step preparation protocol: see, feel, and image. Step 1 is see. You begin by visually identifying the broad anatomical region and the surface landmarks associated with your target vessel. Step 2 is feel. For arteries, you map the pulse with your fingers. However, veins are not pulsatile, meaning palpation alone is unreliable for mapping central venous lines. That leads directly to step 3, image. Modern clinical practice relies on ultrasound guidance to look beneath the surface and confirm exactly what your hands are resting over. Replacing blind physical palpation with structured real-time imaging eliminates the guesswork. It is the definitive standard for preventing insertion errors. Let's apply this protocol, starting with arterial lines. Primary, most accessible target is the wrist. On this hand diagram, follow the red pathway down, isolating the thumb side to find the radial artery. We use the PAC mnemonic here. First, locate P, the pulse at the surface. Next, identify A, the artery beneath. Finally, C for catheter maps your insertion trajectory. Before committing to any puncture at this site, you must assess the hand's collateral circulation to confirm that blood flow will remain adequate if the radial artery is temporarily compromised. Because the radial artery runs relatively superficial on the thumb side of the wrist, it provides an ideal, accessible site for continuous pressure monitoring and blood gas analysis without risking deep tissue damage. Now we transition to central venous lines. One of the primary insertion zones for these lines is the neck. This outlines landmarks for finding the internal jugular vein. Mapping points at the ear, mid-neck, and clavicle reveals the distinct anatomical triangle containing the vessel. The internal jugular, or IJ, runs deep in the neck. Think of it as the inside jugular, sitting protected within the carotid sheath. This simulated ultrasound shows the immediate danger. The IJ vein, the blue oval, sits immediately next to the carotid artery, the red circle. When applying downward pressure, the blue vein easily compresses flat, while the thick-walled red artery remains rigid and pulsates. The risk of hitting the carotid artery makes ultrasound a mandatory safety standard for every internal jugular insertion. When the neck or chest is not viable, clinicians move to an alternative central venous insertion site, the vessels of the groin. This groin cross-section demonstrates how we decode tightly packed femoral anatomy using the NAVEL mnemonic. Sweeping from the lateral outside to the medial inside, the columns represent nerve, artery, vein, empty space, and lymphatics, revealing the vital spatial relationship between the red artery and blue vein. This gives us our critical targeting rule for femoral CV lines. Your target vein is always located medial to the arterial pulse. By internalizing this lateral to medial map, you ensure that a large-bore central catheter is guided safely into the vein, preventing dangerous insertion into the femoral artery. We have now mapped the precise anatomical targets across all three primary vascular sites: the wrist, the neck, and the groin. The golden rule remains constant. You place A lines in the wrist for pressure and gas, and CV lines in the neck or groin for drugs and fluids. Textbook anatomy provides the baseline, but human patients have unpredictable variants. The see-feel-image protocol bridges that gap, confirming your target in real time. With the location verified, the next steps are to establish a sterile field and proceed with the physical insertion, always following local clinical protocols under appropriate supervision. Clinical confidence during the physical procedure relies on absolute certainty in the anatomical map you have created.